Greetings from Washington, D.C. My name is Srinivas Gurajada. I work in the PIFA Secretariat housed in the World Bank. I'm delighted to chair and moderate this session and take you through this very exciting panel of discussions today at this webinar organized by the World Health Organization, World Bank, and Global Financing Facility. At the outset, let me quickly run you through what we are going to do during the rest of 1.5 hours. I'll make some initial opening remarks and transition to the main key presentation of the session. The presentation on the theme of budget execution in health from bottlenecks to solutions based on the recent paper of the World Health Organization and the World Bank. And this paper will be presented by two of the preeminent global PFM in health gurus, Helene Barrow from World Health Organization. Many of you know, with 25 years of experience, she is senior public finance specialist and also the Montreux PFM collaborative lead, which you will hear about a little later. And then we also have Moritz Piatti from the World Bank. Many of you know Moritz as a great influencer. He heads the entire work stream of PFM in health in the World Bank and is a big player and an influencer in this agenda globally. We have this presentation and then move to a panel discussion. For the panel, this webinar and the paper are not just theory. It's a perfect combination of theory and practice. And for the practice perspective, we have three of the big time contributors to this paper who will be joining the panel of discussions. First, we will have Joel Arthur Kinderbergo, Secretary General from the Ministry of Health in Burkina Faso. He's the second highest level official in the ministry, and you would know how much of understanding and insights he would have. We have Marat Kalev, who is from the Ministry of Health in Kyrgyzstan, who has also been a deputy minister of health. And we have Lorenco Pinto, a leader in Ministry of Planning in Timor-Leste and a PFM expert. They will share their experiences from country perspective, after which we move to a question and answer session. That's your time. And finally, we move to bringing all this together, a summary, the summary by Richard Tusabe, a former minister of Treasury in Rwanda. And he has a unique experience of also being having worked in the Rwanda Social Security Board, strong understanding of health, after which he moved to revenue and then to the Ministry of Finance, a perfect combination to take us through the closing remarks. Are you as excited as I am? Let's dive into it. So let me start off with just two quick thoughts. One, PFM in health is a problem. That's what we find in PIFA assessment reports. And what is PIFA? For those of you who do not know, PIFA is Public Expenditure and Financial Accountability. It's a gold standard PFM framework used by ministries of finance in 155 countries. And what we see from the data, it's housed in the World Bank headquarters in Washington. And the data, what we see is whenever there is a budget increase, the overall budget increase in a country because of greater revenues or other reasons, the ratio with which the money goes to health is not proportionate to other sectors. It's lower. On the contrary, when there is a budget cut, very often in developing countries, the cut is likely to fall stronger on the health. Why? We don't have answers. And that's what we will try to dive deep in this webinar. Number two, PFM is work in progress in developing countries. There is huge scope for improvement looking at the PIFA assessment reports. So if someone from Ministry of Health says PFM systems in a country are not working too well for the Ministry of Health, you have good reasons, but it is still work in progress. And that's the gap which we need to bridge. And that's the solutions that we are talking about. For good PFM systems, you have a rough proxy of budget execution. And if there is budget reliability and good budget execution, it actually would mean that the PFM systems are delivering pretty well. The good news is over time, since 2005, all the 155 countries, if we see the trajectory of PFM changes, PFM reforms are working, PFM systems are improving. But are they really working well for health sector? Let's dive deep. With that, let me turn to Helen and Moritz for their lead presentation. You have 20 minutes and the floor is yours.
Perfect. Thanks a lot, Srini. And I think it's really a perfect introduction to the topic indeed. Oh, well, I'm really pleased to be connected with so many of you. I see that many of you are connected with us for this session. It's really great to see such a strong interest for a complex topic. So really appreciate this opportunity to be with you this afternoon. Before diving into really the details of this report and this area of work, I wanted just to start by sharing actually what motivated the development of this work. So this work between us in WHO and the World Bank teams really started 3 years ago in 2022. And I think it really started in response, as Srini said, to really a long overlooked issue, the issue of low budget execution in health, in the health sector. And I think we all know that historically, the focus has been on budget allocations. I think it's true for research work, probably, but also for policy discussions and actions. So focus much more on how much funding is allocated, how much funding is committed to the sector. But the question of how well or how effectively, I wanted to say, those resources, those domestic resources are actually used and utilized. So this question, as we think, received far less attention. Again, probably both in research and in policy discussions. I think the issue has also remained largely invisible. I think it's valid at both national, but also at the global level. And I think it's mostly because there was a lack of data or lack of consolidated data. So budget execution in the sector often remains a black box. So I think it's really what has motivated the start of this new work stream between us and the World Bank. So being really cognizant of all those issues, we've decided, so 3 years ago, really to join forces. I think really with the idea to bring this issue of budget execution into the spotlight and even more importantly, onto the political agendas. So this collaboration has really culminated in the release of a joint synthesis report. So you have the cover here. It was released earlier this year in 2025. What the report does is that I think, first of all, it provides some conceptual clarity. We do explain what is budget execution, but also why this is important, why it matters for the sector, why we should all care about executing budgets in a full mode in the sector, the fact that it has a direct influence on the delivery of services and so on. So we really start from providing this kind of conceptual clarity. From there, we actually provide, I think for the first time, some data trends. We've compiled data coming from 2 major sources, PIFA and Boost. But we've done a lot of work cleaning the data sets, validating data with countries. So we compiled the data set for more than 90 low and middle income countries for 10 years, covering 10 years, 2010 to 2020. And through that, I think we've been able really to estimate or show how big the problem is, right? Because I think we all had kind of anecdotal evidence and data here and there, but I think with the report, we were able to put things together and, for example, show that for low-income countries, indeed, the problem of budget execution in the sector seems very, very significant. We showed that an average of 13% at least between 2010 and 2020 in low-income countries was actually not spent, was unspent, if you compare it with how much was allocated to the sector. Second, I think what the report does offer, which is also important and what we will be discussing in the next slides, is really to provide, I would say, an analytical framework or just an approach to be able to identify the causes, right? The drivers. So really opening up, unpacking this black box that I've mentioned earlier. So really trying to provide an understanding of what is behind low levels of budget execution and what are the potential drivers and causes and sub-causes of this challenge. Last but not least, and this is what Maurice will cover in a minute, we try also to move beyond just the diagnostics and we do elaborate quite extensively on potential solutions, because this is really one of the goals that we wanted to fill with this piece of work, is really to try and inform potential solutions that can help countries really in moving this agenda forward. You will have all the links for all the materials, the case studies, the synthesis reports at the end of the presentation. Today's webinar focus, knowing that when we saw the registration for today, we understood that actually many, if not most of you, were country experts, country colleagues, really working at the level of countries. So for this main reason, we decided that, of course, we will not cover the entire scope of the book, but we wanted to focus actually on two key areas, two components and aspects that are covered in the report. The first thing that we want to do is actually to briefly summarize, introduce, reflect on the analytical framework that was developed as part of this work. Really, again, with the view to provide support to help countries in the future identification of those budget execution challenges. And so this is what I will be covering in the next slides. The second key areas that we would like to focus on for this session is really to be in a capacity to elaborate and reflect on some of the potential solutions, good practices, ideas that could be potentially tested, introduced, scaled up in countries again. And this will be the focus of Mauriz's talk in a minute. Last word on, I would say, the intention of the discussion today, and I think it's really valid for our presentation, but also for the country interventions. I think the goal is really to show that addressing budget execution challenges really requires a, I would say, proactive collaboration between health and finance actors, between health and finance actors across all the levels of government. So you will see that we will often come back to these collaborative functions, which we think is really, I would say, a critical enabler for moving this agenda forward and for fixing or trying to fix the problem. So now let's go to the first part of this presentation that I will be focusing on. I want to briefly walk you through the framework, the analytical approach. You will see it very simple. It's not a very conceptual framework, but just an approach that countries can actually use to build really a shared, a common, a joint understanding between health, finance, and other actors. So a joint understanding of the issue within governments. So across countries, I say with the evidence that we have across many low and middle income countries, it seems indeed that budget execution challenges in health are not just a health sector problem, right? We often hear that, yeah, you know, poor budget execution is mostly due to low absorption capacity in ministries of health. But what we've been observing, actually country after country, is that execution is actually influenced by every stage of the budget cycle. So it's not only about the execution phase, it starts much more earlier, from how the budget is actually formulated and structured within budget proposal, to how is it disbursed, to how is it controlled, to how is it accounted for. And so we've came to the realization that all that features, all the different stages of the budget cycle do directly influence the level of execution. The other thing is that execution in the sector depends on rules, on decisions, on processes that go well beyond the Ministry of Health, right? So not only an issue of absorption capacity of the Ministry of Health, it does involve finance ministries and subnational entities. So through this simple visualization of the problem, I think what we wanted to show is that we wanted probably to shift from, I would say, probably a too narrow perspective on what is often perceived as budget execution in the sector. So a narrow perspective of it's only limited to the absorption limitations of the Ministry of Health. So we wanted to shift from that perception to probably provide a broader, comprehensive understanding that indeed budget execution in health is actually probably a multi-factor and multi-actor challenge or problem, okay? And I think this kind of visualization that we're sharing with you today is probably also helpful and valid to drive country policy discussions, right? Kind of positioning budget execution in health challenges in this broader ecosystem instead of just narrowing it to a particular issue. We think it's much more actually aligned with probably the country's public finance realities of today. So next slide, moving from this kind of holistic approach, if you wish, what we've tried to do is to categorize the most common drivers of poor execution in health, poor budget execution in health, and following the approach that I've just presented, we've tried to categorize those different issues by stage of the budget cycle and by stakeholder. So you see here how we've used the matrix. You see the example for budget formulation. So here the point is really to identify issues that from a budget formulation perspective may have an impact on the level of spending. So for example, as we can see on the left-hand side, poor budget credibility, or on the right-hand side, rigid budget structures that are too much centered on specific line items. All of that can hinder the ability to fully spend, right? So we've been trying to really look at the causes and the sub-causes of the problem, first for budget formulation, and then also for aspects related to the execution stage, and then aspects related also to the oversight phases. So I won't go into the details here. Actually, the details are available in the synthesis report. But what we wanted to do is that by sharing the essence of this approach, we were hoping to show that it can actually, I would say, be used in countries to identify the causes of poor budget execution in a relatively simple way, as you can see, but still in a comprehensive and holistic approach. So moving somehow the needle from just seeing a problem to really try to unpack where the main bottlenecks stand. So just to close on that, and then I'll pass the floor to Moritz. So unpacking the causes like this, as I've just said, we think it can really help probably move beyond the blame game that we often see between health and finance actors. This is your responsibility, this is my responsibility. So So really to try and enable the identification of targeted solutions, right, across stakeholders, across budget stages, because each problem that then would have been identified can then be linked to a solution. Okay, so really trying to first identify the problem, and then it really helps to identify some practical options for actions. And this is exactly what Moritz will be focusing on the next slides. Over to you, Moritz.
Thanks so much, Hélène, and good morning, good evening, everyone. Thanks also from my side for making the time to join us here today. I would like to reiterate that what motivated us to do this work was perhaps not so much the discussion around why it matters, which has, of course, already been subject to an exhaustive debate, but rather to go beyond the surface, right, and talk about all of the things that Hélène already brought up, right? What drives budget execution performance, and what are the causes, the sub-causes, and then the natural follow-up question, well, what are we going to do about it? What can we do about it? Where's the reform space? And right, it's, my task was here to talk about solutions, but solutions is really a very big word. Right? These are not cookie cutter type solutions that can apply everywhere. Rather, right, the way we think about this are options or approaches that may be worth considering. So as Hélène already mentioned, budget execution challenges are rarely just the business of one entity alone. And that is what we need to move away from, right? This blame game, right, which she had mentioned, right? Which is really not constructive, right? To be in a situation right, where to move away from this blame game to a situation where there is a joint understanding and joint ownership of the problem, right? And that's what we're trying to show here through this matrix, that there is a joint appreciation, and that then underpins the process of finding a way forward, right? And this is what we're trying to communicate with this matrix. So any of those challenges, right, that you see here, right, that Hélène mentioned, like, be it related to formulation or execution or otherwise, right, you map this into the matrix and connect the relevant actors and role to it, and then you need to work through what the role of these actors are, right? So you work backwards. You say, here's the problem, and what are the causes, the sub causes, and what drives this problem, and then how do the various actors contribute to it? And only then, once you've thought through this process, right, do you have a meaningful basis for taking policy actions that stand the chance of making a difference. Right? So you identify what, you identify who, what is going to make a difference, and is there actually a reform space? So in the next 3 slides, I would like to go into some more depth in this, to give some examples and building on the problem statements from Hélène, and show perhaps some concrete actions that individual entities can take. Right. So what you see here, right, in these next 3 slides is like what, right, there's the problem statement up front, and then there are questions, okay, of what is it that a Ministry of Finance can do, right? What is it that a health ministry can do? What is it that a local government can do, right? And the first one here, right, in this slide is the issue around budget credibility. Right. So the problem, right, that many of you are familiar with is that if you don't have a credible budget, it's going to be very difficult to execute the budget well. Right? So what can you do about that? And again, that there's the potential for this blame game. Ministry of Finance can say the health ministry doesn't spend the budget allocated. Health ministry says, we didn't get the funds released to spend in the first place, and so goes around and around in a vicious circle that really benefits no one. Right. So taking a look at the Ministry of Finance, right? Perhaps kind of an obvious action to take is to say strengthen capacity for more accurate revenue projections, right? So yes, that may be something easy enough to say, but how actionable is this really, and how helpful is this really, right? So then you can dig deeper and say, okay, well, sure, that may be one thing that matters, but one thing that also matters is to protect such projections from potential political interference, and then connecting that to the service delivery by sectors by saying, look, inflated projections actually have real world consequences on the ground. It makes a difference to the services delivered, and that is felt by real people, right? And that is where there is a need to reach across the aisle, right, to be able to make that connection, right? And where the Ministry of Health can potentially come in, right, to say, look, you need to be able to understand the upstream issues, but also communicate the consequences of what that means because they can't execute the way they would have liked to, right? So that then the finance stakeholders in turn can use the impact that is felt on the ground to its own advantage, right? And that is just so there's the interconnected pieces that on the role that the various stakeholders have in this is important to be able to understand who needs to do what, such that the overarching objective or problem can be addressed. And this is just one. This is just one example, and in this slide there are many other bullet points that that are displayed here, and that you'll be able to walk through in the report. But I don't have time to go through everything here. But the point that we really want to try and get across is that these things are interconnected. Finance has a role, health has a role, and that that it may be complex, but it's possible to do something about it once you're able to isolate these factors. So in the next slide, I'll go into another issue, right? And one of the things that Ellen showed in her slide is the regularity and predictability of fund flows. Again, something that gets mentioned quite often as being a bottleneck, right? And something that affects the ability of service providers to do what they need to do, right? So how do we shift towards a process that that addresses this issue, right? And again, you can say, well, we need to strengthen general cash management practices, right? And then you can work on that and say, this is a Ministry of Finance type role. If we don't figure this out, this is what needs to be done to do it. But this is, again, a very simplistic way of thinking about it, right? Because things are interconnected, and it's important to figure out what exactly is it that the Ministry of Finance seeks to do, and what is it that's important to the Ministry of Health, right? So going into more detail here, perhaps, right, is that when oftentimes when we talk about strengthening cash management practices, we talk about strengthening the Treasury single account, right? And right, for efficiency purposes, and part of that is sweeping all idle balances, right? Now that can mean sweeping all revenue that's generated within the health sector, right? So the Ministry of Finance can say, well, we try and strengthen cash management, but by doing so, it may actually take away the liquidity that the health sector has to address burning needs, because there are fundamental cash management challenges, right? And what I'm not trying to say one is right and the other is wrong, but I'm trying to say that it's important to balance perspectives, right? And that perhaps until there is confidence that the cash management practices across the country are solid, the health sector needs to be able to operate, right? And perhaps this trade-off between retention of some resources within the health sector and sweeping everything to finance needs to be explicitly discussed, whether that requires everyone to come together and be able to reach across the aisle and understand the perspective of the other entity. Right. One other example that we could dig up is this question around cash rationing. Right, that is something that can be anticipated. Right, in many countries you have cash rationing year on year, and then it becomes something that is predictable. And if it is predictable, one can be deliberate in the prioritization process rather than being reactive. Right, and then that points to a specific direction where finance and health can actually take action to make budget execution processes more effective for better service delivery. The last example is shifting the approach to expenditure controls. So many of you would have heard that input-based controls can be prohibitive to health operations. Yes, of course, right? It can be prohibitive to spending, and that is consequential to budget execution in health. But again, what can be done about it, right? And what is the finance perspective? What is the health perspective? What is the perspective of local government? And again, it's this question of finding the intersection and finding the perspective of the other entity, right? So when we talk about this,
one can think about, okay, what does an enabling environment look like that balances control needs with the needs of health service delivery, right? And that may require a differentiated approach to a control environment, right? Where one considers or one asks the question of where are the high-risk transactions, where is this control really needed, and what is needed from a service delivery perspective. And maybe we can find a way forward that addresses both needs. Right? So it's not so much a question of control or no control, right? Or but rather having a deliberate and differentiated approach to taking these controls, because the objectives across government are going to be multiple, right? Expenditure control and fiscal discipline, of course, is a very valid perspective, and service deliveries too. That's just a question of how do we shift towards something that makes sense to all entities. So I've just given 3 examples, but there are some common attributes across all, and I'd just like to spend a minute on this. Right? So one is to communicate and build trust. Right? Really makes a difference to make communication explicit, right? And be able to understand where the other entity comes from, and that then builds trust, which is fundamental for progress. Right? And then one really needs to think about all of the entities involved. Right? The other is be deliberate and not reactive, right? So sometimes this prioritization process that I talked about can anticipate cash rationing, and being deliberate and not reactive cuts across many of these problem areas and across the entities that we talked about. Then consider second best options. Right? So when I talked about cash management issues and the role of a treasury single account and what does it mean for health, yes, right. From a theoretical perspective, maybe sweeping all balances will work. But if that doesn't work today, what does it actually mean for how we're going to operate, and where is the health sector in all of that? Right. So one does eventually need to think about second best practices. And as the question around partial reforms is something that's come up, right? I don't want to spend too much time on now because I didn't address it earlier. Being purposeful about expenditure controls. Right? So rather than kind of having a sweeping set of controls, what is it that we're trying to achieve with these expenditure controls, and kind of being cognizant that controls and accountability are perhaps 2 separate things. And lastly, one thing that's come up is the importance of delegating authority, right, and the role of autonomy across the sector, and what all of that does for budget execution practices and accountability. So before wrapping up, I would like to just introduce you to some of our reference materials. Elaine's pointed these out earlier, but here you'll have them with QR codes and embedded links. When we share the slides afterwards, you'll be able to download these or access these as needed. Right? Again, there is the synthesis study. There is a case study series from the World Bank, the WHO publications. There are also 2 blog posts that we would like to recommend. These blog posts have not been written by us, but they do a fantastic job at summarizing our work succinctly, so we wholeheartedly recommend them. And then some acknowledgements are due. Like, I would sincerely like to acknowledge the inputs from a very big team. I can't list everyone, but the teams have been important both at the global level as well as at the country level. Right? Without the country level inputs, we would not have been able to get the type of granularity that was really needed to get this work done. Then we'd also like to extend our gratitude to the PIFA Secretariat, Srini and team. We wouldn't have been able to do the data analysis without the data that was made available by the PIFA Secretariat. Especially, there's been this effort of pulling out the data from the annex of the PIFA assessments, which was really a lot of work, right? As well as from the boost teams at the World Bank that made data available. And then, of course, we'd like to acknowledge and appreciate the financial support from the WHO-UHC partnership, the Gavi Alliance, and the GFF. With this, I'm handing the presentation back over to you, Chair, and I'm very much looking forward to hearing from our senior country participants. Thanks again.
Wonderful, Helen and Moritz. I can see from all the chairs, thumbs up and coming up on the screen. It's very, very well received. Stop a blame game, have targeted solutions, health and finance coming together, control versus flexibility. Personally, I felt this particular product is one of the most important contributions, not just for PFM in health, but for PFM practice worldwide. And hearty congratulations to the entire team for putting it together. And colleagues, actually, this has been also like, I see a very exciting and a lively chat and a very disciplined group where the questions are moving also to the Q&A section. Please continue to put your questions as we now transition from the presentation to country experiences. We'll start with Joel. What's your take on the report and this entire work, and what do you bring from Burkina Faso, your country experiences? Over to you, Joel. You have 5 minutes.
So hi everyone, and thank you for the opportunity to share Burkina Faso experience. And today I would like to highlight one of the main challenge we face in the health budget execution, that is the complexity and authorization of spending procedure. And before any funds can be used in Burkina Faso, multiple signature and validations are required at different levels, and this creates a long delay in the procurement. And here we can see some figures, and we see that it's go down and up. And the result we see is that usually in the first half of the year, execution rates are often low. And at the end of the year, we see a rush to spend funds very, very quickly. And so the solution that the government tries to address these issues is to introduce in August 2023 a decree that set out new procedure for public procurement, especially in the context of implementing specific projects. And what do we mean by specific project? Specific projects are investment or any other acquisition of goods and services that the government has identified as such, and it intends to carry out in a relatively short time frame in order to address the context of insecurity the country is facing and subsequent humanitarian crisis, or to increase the capacity of the administration or the resilience of the population. And the goal of this new reform is to reduce administrative bottlenecks and give more flexibility to health programs. By making the procurement process faster and less bureaucratic, we can better align the execution of the budget with program timeline and service delivery needs. So what achievements are we able to see? So although the reform is still recent, we are already seeing some positive results. And in project when the decree has been applied, procurement and disbursement are faster. And this has improved budget execution rates in some health programs. We also see a more regular flow of funds across the fiscal year instead of everything being spent at the end. And importantly, spending is now better in line with the needs of service delivery. But we are still some challenges because even with good results, we need to be very smart in the planning, because this is not flexible, and if we need to change something, we need to obtain a new approval from the Council of Ministers. So in conclusion, what we can say that improving budget execution is not just a technical issue, we also need political support. And by simplifying procedure, we have started to make sure that the resources reach facility and also service delivery as planned. Thank you very much.
Thanks, Joel. That's brilliant, and actually it echoes so well. Like procurement is at heart of public financial management, and actually getting it right would have significant influence. And you pointed out very well, and the need for having political support. It's not just a kind of a technical exercise. Thank you so much for the great intervention. Let me now turn to Marat and seek his reflections. So, Marat, how do you see in Kyrgyzstan things work, and what's working, and what were the solutions for the problems?
Thank you very much, dear colleagues. I would like to thank the organizers for the opportunity to present Kyrgyz Republic experience.
Kyrgyzstan is, of course, in Central Asia, has 7 million population. As a result of reforms in the last 20 years or so, 80% of the budget is channeled through the mandatory health insurance fund, 20% through the Ministry of Health. The insurance fund buys services based on payment for results. These financial flows in the health ministry indicate different approaches. Next slide, please, in budget execution. Here in the diagram, we can see that one of the key problems that complicate the health ministry's operations is cash rationing and cash gaps. Up to 30% of allocations are delayed during the first 7 months. As a result, execution in the first half of the year is low. Expenses increase dramatically in the last few months of a year, and what should have come in H1 is carried over to H2. As a result, institutions have to absorb large amounts of funds on a very tight schedule, which of course negatively impacts the services quality. The red line refers to the insurance fund. The blue one refers to the health ministry. What we can see is that even during the COVID period in 2020, the insurance fund ensured consistent funding, and cash flows remained predictable and approached 1/12 of the annual budget. A completely different situation was to be found in the health ministry, where the bulk of expenditures is towards the year's end due to centralized procurement. In 2019 and 2020, this trend exacerbated, and what it meant to medical institutions was delays with supplies of medication and difficulties in provision of services. The insurance fund was able to ensure consistent and even flow of services. To overcome these difficulties, Kyrgyzstan has effected a number of reforms, such as automation of the treasury single account, where all funds go through the treasury account, and that has reduced delays and resulted in better distribution of funds across the year. Another thing is carryover rules, which were only for the insurance fund. Those balances are reflected in the budget. Now, funds that were not used in the previous year can be carried over to the next year, which has largely undone the bunching practices and has created a positive impact for organizations funded by the insurance fund. Unfortunately, this practice is not being used for or by the health ministry. Number 3 is unified accounting and reporting system for all health institutions, which has improved transparency and allows for comparison of data based on different sources of funding, and has increased accountability of providers. Funds that were previously sent by insurance fund to fund medical institutions were handed over to the health ministry, which created certain risks. The annual law on insurance fund budget remains a practice, and also reforms are still carried out in terms of automating single treasury accounts and a number of others, including carryover of unused funds and a unified accounting and reporting system. These measures enable predictability planability and helps undo the bottlenecks and maintain transparency, even in a situation where financial flows are being changed on account of political decisions. Thank you for listening.
Thank you very much, Marat. That's very insightful thoughts from the country perspective. And particularly, I would like to, you specifically focused on the cash rationing point, and the cash, something I could relate also to what Moritz said earlier. Can there be a program budgeting during cash rationing environment? Something which probably we can, I see some questions also coming up on that, and we can discuss that in the question and answer session. But your intervention has been bang on target. Thank you so much. Let me now turn to Lorenco. So how do you see from perspective of Timor-Leste? What are your reflections?
Thank you, Srini. Good evening, everyone. For this session, I'd like to focus on the budget execution studies that was undertaken for the period of 2017 and 2021. And the focus will be on the low performance in health budget execution in Timor-Leste. As you can see from the slides on the left-hand side, that the total allocation for health budget in Timor-Leste has been ranging between 64 million to 97 million, where the average allocation was around 70 million. And in terms of the execution rates, the average execution was approximately 88%, where the lowest execution rate was in 2021, that is 76%. So this is where the COVID-19 hits, and then most of the budget execution were not happening during that time, especially with the weak health system in Timor-Leste. If we see that across the columns, if we also put down the percentage of the payment in areas refer to the payment that's been contracted, obligated, but not been spent during the period. And it is ranging from 0.7% to 3.5%. However, the average was quite small comparing to the total expenditure was around 2%. However, if we look further to the non-obligated or remaining budget that were not spent, on average, approximately 11%. 11% of the health budget were not spent. So those budget that were not spent, if we look into the the right-hand side, that there are different category of budgets, allocation and execution. So there are actually 5 economic classification category where the health budget, according to the Timor-Leste PFM system that's used to allocate and spend the budget. So in terms of Timor-Leste context, we have recurrent budget and also capital budget. So if we see in the slides that the recurrent budget will include salaries and wages, goods and services, and public transfers. I would like to highlight here is public transfers. In other term, also public grants where the government used this account to pay for overseas medical services or the services there is no existing specialized services. That's why the government is contracting out the specialized service to the overseas hospitals, and then payment to medical supplies, equipment, and also medicines. So in terms of the recurrent spending, recurrent capital budget execution, the spending is quite consistent, above 90%, while the main problem is in the capital spending. So this is where I'm going to focus, is that with the capital spending, minor capital, and also with the capital and development or infrastructure fund. So capital and development fund, in 2019 and 2020, the government had allocation to infrastructure fund. However, it was not spent due to the COVID hit. So the execution was zero during that period. And the major contribution to the low execution in capital and development budget was due to project readiness, where the health budget that's allocated for infrastructure fund. Some of the project they did not have this what's so-called the feasibility studies, and also some of the calculation for the built-up quantity. So it all linked to the project readiness. So as already covered earlier, that in terms of the PFM system, how the government tried to address this is that when we identified during the study, we identified that the root causes, the issue was linked to the weak PFM system. So in terms of the PFM performance itself, there is weak capacity in budget preparation. So this is linked to budget planning, and also with the low execution in infrastructure is also linked to the spending rules, where the spending agencies, there are fragmented, or there are fragmented roles with that's responsible for the execution of the budget. So for example, with the infrastructure fund, an allocation of less than 5 million will be executed by the Ministry of Health, and then a budget that's greater than 5 million will be allocated or will be pooled under the infrastructure administration fund, where the execution process will take much longer. So there is a cumbersome in the process to spend. And also with the spending control, where the Ministry of Health and then the health centers, they have lack of autonomy in terms of controlling their spending and also execute their budget. And another weaknesses is in the procurement system. So the procurement of drugs, medical supplies, and equipment, in recent years, we have faced challenges in terms of the stock out, and that is the issue is linked to the system, and also with and if there is an issue within this, then it also affects the overall budget performance, budget execution performance. So the solutions that the government has considered, as the Ministry of Finance is leading the PFM reforms, and as already mentioned earlier, that the PFM reforms is an ongoing process. So the Ministry of Finance, in collaboration with the Ministry of Health, have been trying to improve the PFM system that can meet the health sector to accelerate the execution. That is one specific overall PFM reforms undertaken at the country level is the transfer of spending authority. So the delegation of the spending authority to the Ministry of Health. And the second one is on the program-based budgeting. So the government actually improved how they control the spending. One is from the detailed input-based spending control to program level spending. So that gives the flexibility to the Ministry of Health to execute. And also with the implementation of the digital payment online tracking system, where Ministry of Health and also the vendors, they can track their spending over the integrated financial management system. So for health specific actions, the government, as I already mentioned, that it's actually with the program-based budgeting and also some other performance-based financing initiatives has been ongoing, and then it has been implemented at the Ministry of Health. And also it provides the flexibility, greater flexibility to the Ministry of Health and then as the budget holder. And another one is on the system, as the system from Ministry of Health and also the PFM system, they are more integrated from input to from planning to reporting, and then input based monitoring and reporting to program based, and then result based. And in terms of the final solutions that the government has been doing with support from development partners, donors, is on the provision of capacity building. So since they continue to do the PFM need assessment or capacity needs assessment, where they identify the areas that needs interventions. One is on the PFM and one is on the health financing capacity. So with health financing, establishment of health financing unit within the Ministry of Health, it will actually help the government to improve data-driven decision-making, and that will support the Ministry of Health to make effective policy decision for the health sector. I think that's all from my presentation. Thank you very much.
Wonderful, wonderful, Lorenco. The breadth and depth with which you provided the inputs is excellent, and particularly you touched one of the key issues, the revenue and revenue budget execution versus capital budget execution, something very core. Sometimes one asks this question: if it's just the whole budget is going to be revenues, recurrent expenditure compliant, but capital expenditure is being compromised, how well it's working and what can be done. Thank you so much to all the panelists. Maybe we have about 10 to 12 minutes of question and answers. So in the interest of time, we are slightly running late. So what I would do is I'll paraphrase and club few questions and mention for one round of responses by any of the speakers. And then we can come back to a second round where the speakers can pick from the question and answers listing. So the first one, does really reallocation happen based on national health accounts? Does health accounts really matter? Did the report, while preparing this report, did we get to see any other sectors like education, program budgeting? Does it really improve absorption capacity? So perhaps if we are, how do you see political support, political will around it to make sure that budget execution is working well? And how do you tackle corruption? Let me say these 5 as bullet points, and any of the speakers would want to comment on anything. So let's start with Helen.
Sure. Thanks a lot, Srini, and thanks a lot for the very good, excellent, I wanted to say, questions. I was really reading them with a lot of interest. I'm not sure we will be able to answer all of them. But yeah, with what you've just flagged, Srini, I think I can address 3 kind of sets of groups of questions. I've tried to bundle them a little bit. So indeed, there is one set of questions, but we're looking at the comparison between the health sector and other sectors, especially the education sector. So I really invite you to look at the report. We've been able to compare health with other sectors. We have data for education in particular and a few other sectors. And so you would notice that indeed the health sector is systematically below in terms of the level of execution if you compare with any other sectors. One of the driving factor for kind of observing this situation across countries is that it seems that our sector is particularly sensitive or more sensitive than the others to PFM rigidities, right? The ability or the lack of ability to be able to reallocate across budget lines as the needs, the health sector, the health service needs do evolve within a fiscal year. So the fact that you cannot reallocate seems to have really an influence on health, in health, much more than in education, for example, where the needs are quite fixed throughout the fiscal year. So yeah, there is a set of data and reflections in relation to this topic. And so which is really, I think, the rationale for trying really to focus on some of the specificities that do affect health spending from that perspective. The second set of questions that I'm happy to provide feedback on is in relation to the structure of the budget. In WHO, we've been doing some extensive work on program-based budgeting. We've been looking indeed at the question whether PBB can be actually conducive to better budget execution. And so very briefly, what we've been observing is that, yeah, it seems that in general, budgets that are structured, formulated by rigid line items or inputs, it contributes to lower budget execution. However, when a country does introduce a new structure for a budget, so a budget that would be structured by programs or following an output-oriented logic, it seems that there are some critical design features, including how the budget, how the programs will be formulated, but also the level of discretion and financial flexibility that will be provided to the managers of the fund. All of that will have an influence on the level of execution. We've seen countries where PBB was introduced, and actually there was a drop in the first years of the reform, a drop in the level of execution because all the parameters were not yet in place to be able to execute fully. Very quickly, last set of questions in relation to the linkage between budget execution and provider autonomy. Many of you were asking whether providing much more flexibility at provider level, at PHC level, was actually a potential enabler for improving budget execution. My short answer would be yes, it seems. We've done some subsequent work in Indonesia in particular. In Indonesia, you have 2 stages for PHC facilities, one of which provides much more financial flexibility. And what we've been seeing through very recent results is that those facilities that do have more flexibility, they can retain funds, they can reallocate across different budget lines, they are more flexible in terms of procurement. Those particular facilities have better budget execution rates. So it seems indeed that providing more flexibility can be actually contributing to better budget execution. I'll stop there. There are many more questions, and I know the other speakers will cover them. Thank you.
Wonderful, Helen. And Moritz, as you respond, can you also touch on the donor funded and the use of multiple sources of funding and how it impacts budget execution? Over to you, Moritz, for any of the questions you may want to take.
Thanks so much, Srini, and also thanks to the audience and for all of those great questions. So on the donor question, right, there is the question around fragmentation, and budget execution is invariably going to be more difficult to get right if there are different rules associated with different financing streams, right? Because then you're complicating the situation on the ground, right? And that means, you know, if you can spend money from one source on one set of things, money from another source on a separate set of things, money from another source on a separate of things, then the spending entities, well, need to juggle, and then it becomes difficult to execute. And difficult also to ensure that there is accountability and due process throughout all of those. So one way of thinking about strengthening budget execution processes in an environment where there is such fragmentation is to actually think about whether the execution processes can be simplified and unified. Right? So even if you continue to have a fragmented environment, if you can think about whether there is a common denominator, right, on certain items or a certain way of going about doing things, but then you can also strengthen the budget execution environment. But that requires working with all of the entities and making sure that that is something that one can go about doing. Right? And just as Hélène mentioned on the work in Indonesia, this is also something that applies very much to the Indonesian environment. Second, the other thing that I would like to bring up is the question around corruption, which was brought up, right? And I would like to take a very specific take on this. Right? Sometimes when the fear of doing things wrong, right, or the fear of perceived corruption, right, will push budget managers to avoid risking doing the wrong thing. So even if that is not purposeful, right, they may wish to prefer to say, well, you know, I'd rather not spend because I don't want to really get into trouble, right? And then you end up in a situation where money, money was budgeted for, money was released, but it was actually not spent, right? And it may not have been spent for all of the wrong reasons because the need is there, right? The point is just that, you know, if you don't know, who has the sign of authority, are you doing the right thing? And we've seen this during COVID, right? That people started spending because they were encouraged,
But then years later, they were being held account, and even though they thought they were doing the right things, they faced legal consequences, right? So the corruption issue is it's really there are two sides of this coin, right? And I would really like to emphasize the side of the coin that oftentimes doesn't get as much as attention, right? The fear of doing things wrong, which may leave important budget underspent when the need for spending is particularly high. So, and one way of going about that, of course, and building on what Elaine said, is the autonomy question, right? So if you delegate authority, right, and you give people the authority to spend against need in an environment with reduced controls, right, then you're also telling them, look, you spend, you're accountable for delivering, and you still have to give us the receipts, but the type of controls and the accountability arrangements are perhaps a bit different from how they are often being set up. Thanks. Back over to Srini.
Thanks, Moritz and Helen. I'll come back to both of you. Can you please think of a response also to a question on like what you think are an entry point for civil society organizations to contribute, and how can simplified financial reporting take place? And in the meanwhile, let me turn to our country panelists if they have any interventions. Joel, any reflections on what you're hearing, or any of you, what you may be thinking, like after listening to these presentations and going through this, what other things you would have done in your country beyond what you have done? Let me first turn to Joel, if you want to come in at this point of time.
Okay, thank you very much. I want to say that what I said is not only for the Ministry of Health, but it's also for all the other sectors. And in the comments, I see that someone from the DRC asked if we can measure the performance of the Ministry of Finance related to how the execution in the health sectors are done. I think that the Ministry of Finance is here for all the ministry, including in the health. And I think that it's important to consider this and to use as a performance indicators the way the Ministry of Finance and the Ministry of Health and also other ministry to have a good, better budget execution. So I think that this can put a kind of pressure on the Ministry of Finance to perform well. And as I said, sometimes we need also a political pressure to achieve the results we need. And I need to stress this. This is very important, specifically in countries where the technical is not well rooted, and also when the procedure has people exactly. Thank you.
Wonderful, Joel. Lorenko, would you like to come in?
Sure. Yeah. Thank you, Srini. I would like to make two comments on the budget execution in terms of the PFM rigidity. So in Timor-Leste, what we see as key important things is that we don't make significant changes into our PFM system. What we did is we improve on what the existing system is there. And one thing that we really highlight is that one is due to the limited capacity of budget holders. That's why the system remained rigid in terms of how spending categories there, but the improvement is to realign and giving the flexibility to the spending units. So in terms of the control was at the lower level input base, now increased to program base where they have the flexibility to spend, to readjust the spending. But rigidity also comes with quality. So the government is focusing on the quality of spending. That's why after the reform over the year, there are some of the specific items, some of the
Perfect.
It's a way that it can improve the budget execution.
Perfect, Lorenko. So in less than 1 minute, preferably, Helen, Moritz, any last thoughts before we move to Richard?
Sure. 1 minute on the CSO question or questions. I think at country level, CSOs can really help by requesting the sharing of budget execution data. Those data need to be much more publicly available. So CSOs can really help with that. And so the information, then the data can be used by parliamentarians and others to really inform future budget allocations, right? So I think that's really one key action. 2 seconds, because there is quite a lot of questions asking data by spending categories. So if you look at the synthesis report or the country reports, you will have disaggregated data by different types of spending categories. But obviously, I think more work, and this is also, I think, the call from today's session, more work is absolutely needed, required, and really welcome at country level to show data by line items, by programs where they do exist, by level of care. So I do really invite all of you to engage more in this area of work. Over.
Thanks, Helen. Moritz?
Thanks so much, Srini, and thanks again for those questions. On the simplified financial accounting and reporting practices, my main reflection is this: that you don't need to allocate by inputs, but you still account and report back on inputs, right? And I think there's an important difference there, right? Because as long as you allocate and you spend, right, that there's accountability on that side, right? And then on the fiduciary side, there is a different set of priorities, right? And it depends then on who your reports actually go to and what purposes they serve. And the other point that I would like to make here on the financial reporting is that simplified and unified practices really help, right? So fragmentation is almost a fact of life within the health sector. It's just the way it goes. There are a lot of financing sources, but fragmentation need not be a problem, right? As long as you can control your budget execution practices, right? So if you find a way, right, to unify the way that is happening, then you're also simplifying the accounting and reporting practices and needs, right? So if you have a unified way, then the information systems can always pull out what may be needed for different stakeholders, and you can do those type of things at the click of a button. So there are certainly ways of getting around these administratively very heavy challenges that we sometimes face. Thanks, and back over to you.
Super. Thanks, Moritz. Now we come to Richard. As I mentioned earlier, Richard is someone who has seen both sides, from the health side and finance side. And what are your takeaways from this conversation, Richard? We are all excited to listen to you.
Thank you. Thank you. First of all, I want to thank the organizers and people who worked on this report. The report is so insightful, and the discussion has really been smooth and speaking about the striking points that we need to address. And the country experiences are equally trying to tell us the story that we more or less know, but with different contexts from one country to another, and having no one-size-fits-all solution. So in my view, the discussion and the report, I see that whatever we do, we need to look at the budget cycle in its entirety, from formulation to execution to oversight and reporting and audit. So what that tells us is that we need a very strong stakeholder engagement. And when I talk of stakeholders, I think the report again has really touched that, and even the presenters. You're talking of the government, and the government is divided into two: the central government, the local government. Then a very important actor is called the development partner. Because at the end of the day, we've talked about the MDBs who are really trying to finance the health budget. So what is the role of each and every stakeholder to carry a shared sense of responsibility and commitment to ensure that we deliver on a health cause? And in the report, I've picked about close to 4 or 5 items that I want really to emphasize. And one is strengthening technical capacity and institutional capacity. The institutional capacity is very important in the sense that if we don't have strong institutions, be it the Minister of Health, be it the Minister of Finance, there is no confidence in the other stakeholders to use their systems. And that goes back to touch a point that has been raised by the presenters on fragmentation. You find that some of the financiers of the health sector do not have confidence to put money into the hands of the government because the institutional capacity is weak. The same goes to the technical capacity of the staff, right from planning, revenue forecasting, to costing of the health budget, to implementation. So we really need to focus on capacity, both for technical staff and institutional capacity, if we are going to really be successful in delivering on health necessities. Number 2 is the constant dialogue between the Minister of Health and the Minister of Finance. And the chair, you mentioned that I've been on both sides. Yes, I have. But the biggest piece of work starts from the formulation part. Because health delivery, most of the health programs, it's not a 1-year program, it's a 5-year program. So that requires you to embed it into a medium-term fiscal framework, which will give a chance to every stakeholder to know where am I going to intervene and at what point and at what level. So formulation to execution, the Minister of Finance has to be engaging with the Minister of Health right from the sector strategic plan to medium-term fiscal framework. Then the annual budgets will come through and give a chance to implement with efficiency and effectiveness. Number 3 is the dynamism in the health sector. We need to adopt a programmatic and responsive approach in the sense that whatever you've committed for in the medium-term strategy has to change as and when needs arises. I think the presenters have talked about autonomy. So you need to set a budget framework and budget rules that allow the actors to be responsive as and when the need happens. So you don't have to really tie people's hands and then you say, go and execute. And that's why I think people have talked about sending money in the second half of the year when you've already missed a chance to deliver on the program and not being allowed to carry over the funds that have not been used. So number 4, I think we need also to adopt to predictability and certainty in the funds flow. So going back to formulation, going back to medium-term fiscal framework, it gives you a chance to have visibility and certainty of what is going to be financing health programs, and then give a chance to all the actors to plug in a timely manner with the right weight and prioritization. So predictability and certainty of funds flow is extremely important to give a chance to service providers, development partners, and the government to ensure that they execute better and in a timely manner. The last one, I think, which also we need to accept and acknowledge, we are in a very opportune time where we have technology taking over. The presenter has shared experience in terms of where they stand. we have the FMS, the financial management systems, we have health systems, we have procurement systems. So how do we integrate all these systems to ensure that they serve us better to deliver on the health cause? So can we enhance and embrace big data capabilities? If we embrace big data capability, then we can make informed decisions, plan better, and execute better and ensure value for money in an environment where the fiscal space is narrowing. So in summary, I think the report, the presenters, the country experiences have given us really what we need to do. It is time for us now to go and engage the authorities, the governments, the stakeholders, that look, we are not only talking about the bottlenecks, we have the solutions which we can customize and say this to the political leaders to buy into, and then we execute better and ensure that we deliver on the health cause as opposed to really focusing on the compliance, which really becomes a bottleneck in the end. So as I leave this webinar, I think I'm really, really excited that we are equipped to implement better, execute, and deliver on the health cause. I thank you.
Fantastic, Richard. That's absolutely presidential minister-like, and you summarized it so well. Strong health ministry, strong finance ministry, absolutely needed. Completely agree with you the way you put it. Let me just say that the budget execution in PIFA, we say there is always an exception year. 1 year in 3 years is okay to deviate. If you're consistently deviating, that's where the problem comes. And what I find from this discussion, my takeaway is the outlook is brilliant. Colleagues from health sector, you are doing really well. What you are sitting as head of PIFA, I get to see what's happening in PFM in 155 countries. What you're saying is being listened to. Ministries of Finance are listening to you. And colleagues in Ministry of Finance and other stakeholders, the demand is high. And Health Ministry is making us faster on improving PFM systems. Let's all come together and make it work. A big thanks to the two presenters, all the panelists, and to the concluding remarks, and all the 600, 700, I don't know. It's like the number seems to be fluctuating, maybe 600, 700 plus participants who joined and made this such an immensely successful program. And with that, let me turn back to Helene. Thank you all.
A big thank you to you, Srini, as a fantastic chair for this session. Just 2 words on the Montreal Collaborative. So this stream of work on budget execution has been jointly conducted, as you understood, between WHO and the World Bank under the umbrella, I wanted to say, of the Montreal Collaborative on fiscal space, public financial management, and health financing. It's a network that has been established 10 years ago, but is really promoting work at the interconnections between fiscal space, PFM, and health financing. And so I wanted to share the information about our upcoming meeting. It's scheduled the first week of December. It will be an hybrid event, which will be this time co-organized between the 6 partner agencies that you see on the right-hand side. It will be hybrid, as I said, so some people will be invited to join in person, but we are also making every effort to make all the sessions available online. So really invite you to register using the QR code. Don't worry, we will send it via email, but I look forward to engaging more with all of you in this meeting. Over.
Thanks, Hélène. And I will say also a few words. So first, really congratulations for those who organized this session today. This was part of the GFF World Bank WHO series. Thanks a lot for this great event, Hélène, Moritz, for setting this up. Thanks a lot for your support throughout these programs of work. Have a nice day.
Thank you, Bruno. Thanks, everyone. Thank you. Bye-bye.
Bye.